Hi, I'm Brad Power, and this is the Cancer Patient Lab, and this is our weekly meeting, our weekly webinar. Today, we're honored to have with us Rob Kimmerling and Dennis Watson of Travera, and they've been working on diagnostics in an important new area, which is monitoring the immune system and doing things to going to describe whether people are going to be likely responders or responding or something about the health of the immune system, which is an important area because the immunotherapies are an expanding area of cancer treatments. And so knowing both who should get them and whether they're responding is an increasingly important area. So I'm really looking forward to hearing about their new diagnostic and any help they may be providing cancer patients and caregivers in knowing whether immunotherapies are right for them. Just a couple of housekeeping items before we get started. This is, of course, for information purposes only. This is not medical advice. We try to arm our patients and caregivers in our community with information that they can take to their medical team. Secondly, everything here will be made public. So if you're concerned about your name, your image, or anything you might say being made public, you can change your name. Uh, don't say anything, and uh, anyway, hide your image. Um, and then finally, we are a nonprofit 501(c)(3), and we depend on the kindness of donors who help fund our operations so that we can bring you webinars like this. It's easy to donate. You can do so on our website where there's a donate button. Okay, with all that housekeeping taken care of, I'll turn it over to you, Rob. Thanks.
Great.
Actually,
Thanks so much for having me. Yeah,
I'm
I'll
gonna
keep
start us off real quick, if that's all right, Brad, and then I'll turn it over to Rob, just with a couple of sort of quick notes from our side. So for those of you that are unfamiliar with us, Trevera spun out of MIT. Rob will introduce himself in a minute, but he is one of the technical co-founders of the company. I've been here for a little over 3 years myself. And it's really a functional medicine company that started in cancer cell testing. And we have expanded our platform and technology into what we're going to introduce today. Rob's going to go through the science, the assay, and a lot of those descriptions. And then in the end, I'm going to close with just a couple of quick slides, sort of outlining some potential utility applications for kind of where the test is at this time, and what drugs we offer, how a patient or a provider could gain access to the test, and just sort of what the logistics of all of that will look like. So we're going to get into all of that, but we're also more than happy to take questions along the way. So all of that said, Rob, I'll let you take it over.
Great. Thanks a lot. Thanks for having us here. I'm Rob Kimmerling. As Dennis mentioned, I'm one of the co-founders and the CTO at Travera. My background is really pretty heavily focused in assay development, single cell assay development, especially for cancer. A lot of the work we've been doing at Travera has focused on exactly that. How can we use single cell assays to help guide therapy selection? And recently, we've been working quite a bit on applying this to the immune system as well and getting a sense of whether or not we can capture the functional response of a patient's immune system and use that to inform their therapy selection a bit more. So just to sort of dive into the actual therapy space, and please stop at any point if any questions come up. I'm happy to kind of pause in real time, whatever works best. And if not, there'll be plenty of time for questions at the end as well.
Rob, could
So
you
just,
just Rob, could you
yeah.
just explain single cell assays? Because I don't think that single cell is necessarily something everybody understands.
Yeah, absolutely. So one of the big challenges when thinking about cancer is often this idea that within a tumor, there's a lot of variability of every cell that's in that sort of compact tumor. And so a big challenge with therapies often is that a drug might only kill a few of those cells, or not all of the cells. So for our version of testing, what we do is we take that tumor and we break it down to all of its components, those single cells, those individual sort of actors, and we're trying to test those cells to see which ones respond to therapies. That same concept of directly measuring individual cells can be applied to the immune system as well. So for what we're going to be talking about today, this is primarily thinking about a blood draw. So from a patient's blood, you can isolate these single cells. So these are things like T cells or B cells or monocytes. And all of these individual components kind of give the full activity of what a patient's immune system can perform. So when I'm talking about single cell assays in this context, we're really talking about T cells most of the time. These are the cells that within a body can sort of target cells that are infected by a virus, for example, or they can target tumor cells. And these T cells actually perform the killing. So that's actually a good lead into the background on the therapy space. When we're talking about immunotherapy here, what we're really referring to primarily are immune checkpoint blockade drugs. So these are drugs that have really come around in the last decade or so into really wide clinical usage. And essentially at their core, what they are capable of doing are reactivating a patient's own immune system to fight a tumor. And in some contexts, these drugs have been really transformative. So melanoma is an example where patients with very late stage disease have had curative readouts with these kind of treatments. And so just to take a quick detour on kind of how they work, this at a high level in a patient's tumor, what often happens is they will have signals, these checkpoint signals, which are effectively signals expressed on the surface of a tumor that tells a patient's immune cells to effectively ignore the tumor. These are the tumor's way of kind of protecting itself from a patient's immune system. This is problematic because the patient can no longer sort of mount an effective immune response and kill off that tumor themselves. So what these checkpoint blockade drugs are doing is they're actually targeting that checkpoint signal. They're antibodies that effectively turn off a tumor's ability to block T cells. So as a result, by targeting that axis, you're able to have T cells that once again can recognize a patient's tumor. These cells can grow and they can actually start to kill the tumor again. And so effectively what we are trying to get a sense of is how can we read out pretty with a high level of certainty what is happening with these T cells. And that's really what we've been focusing on. So as a sort of baseline context for this, these immune checkpoint blockade drugs are used very widely now. So over 40% of patients are now eligible for these therapies, meaning they have some kind of biomarker in their clinical workup that means they are eligible to receive immune checkpoint blockade. Unfortunately, only about 20% of patients that receive these drugs actually have a durable clinical benefit from them. And this comes oftentimes with a lot of pretty harsh side effects as well. So there's a bit of a trade-off in terms of the lack of efficacy and actually having a pretty substantial response just baseline for the immune systems. And then finally, this is a really big portion of oncology drug spending. This is something where almost a quarter of all drug spending is going towards these checkpoint blockade drugs for managing cancer. So clearly there's a pretty big mismatch between the number of patients that are getting these, the number of patients that are benefiting, and the patients that are unfortunately seeing side effects without having any real potential improvement of their cancer. So for those reasons, there's been a really big focus on developing biomarkers to help predict which patients will respond best to these drugs. And there's kind of two key pieces to what these biomarkers are focusing on. Currently, the largest focus is on the tumor biology side. So in order for a patient's immune system to actually respond to a tumor, it has to be sort of recognized as a foreign body. The same way you would recognize a viral infection or a bacterial infection, a tumor has to present some kind of antigen or signal that is not actually supposed to be there. And so a current readout for that are things like the mutation status of a tumor, things like tumor mutation burden and MSI status. These give an indication about how unstable that tumor's genome is, and these are kind of an estimate of how well that tumor will present itself as being foreign to the patient's immune system. And then similarly, within the tumor biology are these direct checkpoint targets. So PD-L1 is one example of a protein that's expressed on tumor cells that sort of tells the immune system to turn off. And if a tumor is expressing a higher amount of that molecule, it's a good predictor of whether or not that patient might respond. So these are the current offerings that are kind of clinically used pretty commonly. But the other side of the coin for actually having an immune response to a tumor is the patient's immune system. Just at its baseline, does a patient have T cells that are fit enough to actually mount a response to kill a tumor? And more specifically, are their immune cells specifically sensitive to different immune checkpoint blockade drugs? That's really the question we're trying to answer with our testing is for a patient's broad immune system, is it ready to actually respond to checkpoint blockade and mount a response to a tumor? And the way we think about this is very physically. And the reason we do that is it turns out for T cells, there's a pretty tight linkage between their form and function. So when you think about a T cell that's kind of in its naive state, this is before it's activated by anything like a tumor or an infection. It's this really small and tight, almost spore-like cell. These are really dense, really tightly packed cells. As soon as those cells become activated, when they see a signal like a tumor or like an infection, the first thing they do is they take in a bunch of water, and those cells have their volume increase very dramatically. And slightly after that, a few hours after that, the cells start to do things like turn on protein production. And as a result, their mass starts to increase as well. And so what we found based on some of the literature back that we at MIT when we were first doing this research is these physical parameters are really good readouts for biologically what's happening in those immune cells. So for example, when a T cell is exposed to stimulation, its mass increases very quickly. We know that the density drops very quickly. And we also know that those changes in those physical parameters correspond to the function of those immune cells as well. So for example, T cells often have two different roles. Some are meant to clear the active threat. These are kind of the effector T cells that are actually doing the killing. There's other T cells that are there for the reserves. In the case there's another event they have to react in the future, these are the memory T cells. Both of those subsets of cells have very distinct physical characteristics associated. And this is something that, again, we had quite a bit of research back in the MIT lab to really flesh out what these mean, these physical parameters mean. But that kind of gets to how we measure these. So these physical measurements are quite useful for characterizing biology, but how do we actually read them out? And so the core platform that we use is something called a suspended microchannel resonator. At a very high level, what this is a very sensitive scale. So what we can do is we can actually weigh individual cells that are coming through this sensor. In terms of how it actually works, this is what's called a microfluidic device, essentially a very, very small scale fluidic circuit that has a little diving board feature in there. And so this diving board is vibrating constantly. And then as a cell passes through this fluidic channel across that diving board, the additional weight of that cell changes the frequency with which that diving board is oscillating. So the concept here is very similar to when you're sort of diving off the diving board. When you're standing at the end, it kind of goes pretty slow. And as soon as you dive off, because it's losing your mass, it starts to vibrate very quickly. That same physical principle is at work here, except on a much, much smaller scale. And so what we're able to do is we can track that change in frequency. And as a result, we can back out the weight of each one of those individual cells that's passing through the device. This turns out to be about 100 times more precise than other methods of looking at cell size, things like imaging or a Coulter counter, which is more of an electrical readout of cell sizing. So what we've done, sorry for the graphics, what we've also been working on is how can we take this sort of core readout of cell mass and start to get additional information, these other physical parameters that we're interested in measuring. So I mentioned we also want to look at the density of these cells, the volume of these cells. So in addition to this kind of core mass readout sensor, what we've been building at the company is a way to layer in things like imaging. How can we take pictures of each of these cells as they're going through and layer on additional information that captures the activation state and the functional state of these immune cells? So at the end of the day, what we end up with is kind of this set of different biophysical properties, including the mass, the volume, the density, and the shape and texture, the morphology of these single cells. That's really what we are using to get a functional readout of a patient's immune cells. So the next step for us was with this kind of core technology in hand was how can we use these physical readouts of patients' immune cells to guide how they might respond to something like a checkpoint blockade drug. So a few years back, we presented our kind of core assay structure. This is the design of the test that we're actually running from a blood sample. So what we're able to do is we can get a sample of peripheral blood from a patient. We isolate all of the immune cells from that blood, and then we test a few different stimulation conditions on those cells. We're getting a sense of how strongly these cells activate just in response to stimulation, but also we're trying to measure how much does that activation improve if we also treat those cells with an immune checkpoint blockade drug. And so early on, what we're able to do is for a cohort of about 50 patients or so, we found that at baseline, there's quite a bit of variability in how well a patient's immune cells activate. So what we're looking at is that's the second panel down here. We're looking at across individual patients, how strongly do their T cells activate in response to stimulation? And we're looking at the direct quantitative physical change in those cells to really read this out. So what this indicated is that there does seem to be quite a bit of just baseline fitness difference for patients' immune systems. And then the other piece that we're able to get from this early cohort is that at an individual patient level, there's also quite a bit of variability in response to these immune checkpoint blockade drugs. So for some patients, when you activate those cells in the presence of something like pembrolizumab, which is an example of one of these ICB drugs, those cells activate much more strongly. Whereas for other drugs, or for other patients, I should say, pembrolizumab doesn't really have any meaningful activation for those patients. I see that there's a hand raised.
Yeah, I had a quick question. So you're
Yeah.
describing now basically your tests as of a couple of years ago. So what I'm confused about is as I recall, your trays wound up requiring, in essence, tumor to go on and function. But the way you're describing it here in terms of T cell activation and the rest of it seems like it could have been done with a blood test. What am I misunderstanding here? Thanks.
No, you're not misunderstanding. So you're absolutely right that this portion is done with a blood test. So one thing that's very different about this assay versus our old assay is our old assay was looking primarily at tumor cells, like you mentioned. So that was looking at something like a biopsy or resection tissue and directly tracking the effect of cytotoxic drugs on those tumor cells. This is actually a new assay that's focused entirely on blood. And what we're looking at is just immune cell function and using that as a way to predict whether or not a patient will respond to these ICB drugs. So you're not misinterpreting. You're absolutely right that this only requires a blood draw for this version of the assay.
Thank you.
So in addition to the variability in activation, I mentioned there's also variability in response to these individual drugs with patients. So that was a really interesting takeaway for this early set of patients was that across 50, there's differences among patients. But really the key question is whether or not those differences are meaningful. So when we measure a different immune response from a patient, does that actually correspond to how they would respond clinically? And so that's a question we've been able to get at more recently with a collaboration we have with Genevieve Boland's group at MGH. And they are focusing primarily on melanoma. So these are patients that are eligible for surgery, but prior to them receiving their surgery, they undergo a course of immune checkpoint blockade therapy. This is called neoadjuvant therapy. So the main idea here is to kind of shrink the tumor in advance of that surgery. And what's really helpful about this context for us is that we're able to collect both tumor profiling and immune profiling prior to those patients receiving therapy. So the idea here is that at baseline, before patients get the immune checkpoint blockade, we can take a blood draw and we can look at whether or not we see a functional response to these ICB drugs and how well that patient's immune system is performing. And then they undergo their neoadjuvant treatment. This is about 6 weeks of therapy that they receive. And then at that point, they undergo definitive surgery. So this is them having what's remaining of their tumor hopefully fully removed. And then at the time of surgery, the pathologists are actually able to determine whether or not these patients responded to that course of treatment. And so essentially what they're doing is just a fraction of tumor cells that have been killed within the sample that's coming out. And from that readout, get a sense of whether or not the patient, in fact, was responsive or non-responsive to the checkpoint blockade drug. What's helpful here about a validation context is that, unfortunately, only about 50 to 60% of patients will respond to this neoadjuvant ICB. So what that means is that we are expecting to have both positive and negative predictions that we're trying to find from this blood draw. The other piece that is relevant here is that these patients are only receiving the checkpoint blockade therapy during that neoadjuvant window. So one thing that is tricky in other clinical contexts is when a patient is receiving both checkpoint blockade as well as radiation or systemic chemotherapy, it's really difficult to back out what the effect of just the ICB treatment was. in the context of all these other therapies. Whereas for this melanoma context, we have a pretty clean way to read out our test versus a clinical outcome. And so in looking at the early data, what we found is that for the first 21 patients that we're through now, in 17 out of these 21 patients, we were able to predict their response to immune checkpoint blockade using just the blood draw. So effectively what we're doing is prior to the patient receiving therapy, we take a blood sample, we measure the response of those T cells to the immune checkpoint blockade that patient receives, and then we correlate that with how well that patient responded clinically based on the pathological response. And what we can see is that when doing this combined measurement of the physical readout, there's a significant difference between the patients that responded and that did not respond. And what's interesting here is it seems like we're able to pick out both of these. So we are able to predict both responders and non-responders, which is quite helpful, something that is very relevant for a sort of clinical biomarker framework. Another way to look at this kind of data is called the area under the curve. This is essentially getting a readout of how much better than random your biomarker is performing. So this AUC readout, for context, something like tumor mutation burden, which is kind of the gold standard of predictive biomarkers, especially for melanoma, has a clinical AUC value of about 0.7. And 1 is perfect, 0.5 is effectively a coin toss and not a very good biomarker. So TMB is right around 0.7. And for us, the blood readout as of now is an AUC of right around 0.8. Which again, as a standalone biomarker, is very valuable. It's something that is performing quite well compared to TMB. But from our perspective, I don't think we view this as the most valuable piece being a standalone biomarker. We do think that the blood test is really capturing immune function, the patient's immune fitness, but it does miss some of that tumor detail I mentioned earlier. It doesn't think about mutation burden, can't capture whether or not a patient will have sort of a signal for the immune system to respond to. So the next piece we tried to look at is how can we take this blood test and pair it with existing biomarkers that are really more focused on the tumor. So for melanoma, this is an example where there's kind of 2 questions that can be answered with the biomarkers. So the first one from the Chirera's blood testing is, does my immune system actually respond to ICB drugs? So for my T cells, do they become more strongly activated if I activate them in the presence of these different ICB drugs? But the second question is whether that tumor is likely to generate an immune response. So this is really the core focus of the existing tumor mutation burden readout. The theory there is that when a tumor has a higher mutational burden, it is more likely to generate these kind of dysfunctioning proteins that look different to the patient's immune system, and as a result can then mount a response against those. So what we did is for this first cohort of patients, there was a subset of 14 of them that had both our blood testing performed as well as tumor mutation burden read out. And what we found is that TMB alone kind of performs similarly to how we would expect it to based on the clinical results at large, was an area under the curve around 0.7. There's only about 8 out of those 14 cases that were predicted with TMB alone. But if you take the TMB data and you pair it with the functional blood measurement for each one of those patients, that combined biomarker now has an AUC of about 0.88. And in this case, I was able to predict 13 out of those 14 cases. So for us, it's still early data. We're really trying to build this out now to get more and more of these cases and examples here. But at a high level, the takeaway is that when we pair a functional readout from blood with these more tumor-specific markers, it appears we're able to perform a little bit better for predicting patient response. I see that there's a hand raised. Happy to stop here.
Yeah, Rob, just a quick question. We know that you're getting your data from a blood draw. Is the tumor mutational burden, is that also from a blood draw, or is that from histopathology, some kind of tissue sample, or how's that done?
Yeah, so for this cohort, it was from a tissue sample. It was from a biopsy of the melanoma earlier on. I will say that we are speaking with some potential collaborators that also get TMB from blood. So there's potentially an appealing kind of co-biomarker that could be developed there, where you're getting TMB from blood as well as the immune marker. But for everything we're showing here, the TMB was coming from the tumor measurement to begin with. So at a high level, this is the main piece of excitement for us is that it appears we have a differentiating biomarker to help make the decision for whether or not a patient will respond to ICP. And so that was really the core of us now launching this in our CLIA lab and starting a registry study that allows us to collect more and more validation data and work directly with patients and oncologists to really refine the assay and collect more evidence for it. So with that, I'll pass it off to Dennis, who can really go through what that looks like, how we can actually measure these samples in our lab.
Could I just ask a quick question about the dynamics? Keytruda or pembrolizumab is like a $10 billion drug, as you pointed out. It's a huge thing for Merck. And so if you come up with a companion diagnostic that basically would say, this patient is not going to respond to Keytruda, go find something else and don't spend whatever it is, 20,000 a dose, or some exorbitant amount of money on Keytruda because it's only 40% effective. And in this patient, it's even less. It's like 10% likely to be effective. Are you going to get pushback from Merck? And what's going to happen when you start to have a companion diagnostic that starts doing what's best for patients, but may not be best for the drug company?
Yeah, I think that is a great observation. I think with Merck, you're probably right. That would be their takeaway. But I think that question, even for oncologists, is often a hard one because if we have a test that says a patient won't respond to Pembro, that's not necessarily useful because that data would have to be bulletproof to prevent an oncologist from using that as a sort of a tool they have to treat. So for us, we very much think about the forward-looking version of this assay is not just to say whether or not a patient will respond to Pembro, for example. It's among a panel of different choices of checkpoint blockade drugs, which is most functionally effective for that patient. So that's why I'm bringing this slide back up here is another piece we found from a lot of our early data is that when you test a patient's blood, what very often happens is they'll have a really strong response to one checkpoint blockade drug, but not to a different checkpoint blockade drug. So moving beyond this idea of whether or not a patient might respond to Pembro, there's a question of whether or not a patient would be better served by going on IPI and Nivo, for example, which is a combination of two slightly different drugs. So I think we view the real clinical value of being able to separate those decision-making points rather than just purely a prognostic readout of will a patient respond to Pembro, which I think would completely agree with you as limitations and sort of how well it can serve patients.
And just to play that a bit further, for staying with melanoma, other than immune checkpoint blockade, what are some of the other treatment options that might be on the menu of that patient? So if they are considering a number of options, what else might be on the list and then therefore might move up the queue based on your test?
Yeah, that's a great question. So often what will happen for melanoma, there are some systemic therapies that are kind of linked to the genomic readout of the tumor. So these are more of the just targeted therapies. There's also for later stage patients, tumor infiltrating lymphocytes as a therapy option for melanomas. This is effectively different than checkpoint blockade. This is where a patient's immune cells are actually removed directly from their tumor. They're grown out sort of outside of the body and they're put back in to go back and sort of fight what's left. And that question, as in terms of how things change in order of priority, I think is one that is really interesting when thinking about this kind of test. Because one thing we've gotten a lot of feedback on is often what will happen is a patient will receive these kinds of checkpoint drugs, which are doing quite a bit of damage to the immune system, sort of by design. They're sort of turning the immune cells on and having them get to a really, really active state. But that might not be best serving the patient that eventually wants to have TIL therapy. And so there's kind of a decision point to be made as to whether or not these infiltrating lymphocytes are healthier if the patient doesn't receive a very long course of these checkpoint blockade drugs that might not be very effective. So I think that's something we still need more data on to see how we do that ordering. But there's a pretty clear set of clinical questions that can be very helpful.
And I would just add additionally, Brad, one of the conversations we had with a breast cancer oncologist, for example, sort of said to the comment Rob was making a moment ago, if your test says that the patient's immune system is not fit enough to likely respond to pembrolizumab, I'm not going to not give it. I'm going to add something to it. Like Rob said, I'm going to give them a CTLA-4 or a LAG-3, one of these other drugs that might help recover that immune response to give us a higher likelihood that the patient's going to respond. And those are drugs that we can also test on this platform, those other classes of drugs outside of just the PD-L1s. Um, so, there's some other added value that we can bring there too.
And can you test drug combinations? That was going to be my next question along the lines of what you're saying. So Keytruda or pembrolizumab as a single doesn't work well, let's say, but we think we're going to do a drug combination with something else, a targeted therapy. Can you test targeted therapy plus, or can you make inferences about targeted therapy plus pembrolizumab?
So for us, we've had some interesting cases where we can run both versions of our assay. We can run both the tumor testing as well as the immune cell testing. And I think those are, right now, those are still run as kind of independent testing profiles where we'll look at the tumor cell response to the targeted therapy and then the immune cell response to the checkpoint blockade drugs. So those combinations are a bit difficult to do in the same assay, but interpreting them are still at the single therapy level quite helpful to have both of those assays run in parallel.
Thank you.
That would require cancer cells, though, from a fresh biopsy or malignant fluid collection. We're not able to do the typical cancer drugs, targeted inhibitors, cytotoxics, et cetera, from a blood draw. We still do require live cancer cells for those, and we can't get enough live cancer cells from a liquid biopsy at this time. Rob, why don't you jump down to my slide? I think I'll hit on one or two things here that might address some of the questions that are coming in, but then we'll go back to the questions that are in the chat as well. This is kind of what the report looks like. If you're familiar with our old reports, it's a very similar layout. We sort of stack rank the drugs that we analyze. We score them from 0 to 100. And essentially anything above a 50 is showing a significant response in those cells that we analyzed, and anything below a 50 is not showing a significant response in the cells that we analyzed. This list of drugs is what we currently have available. Relatlimab is the first LAG-3 we'll be adding, and that's probably going to be available in a handful of weeks. I don't want to hold Rob too closely to a timeline, but that one is in process of being validated. And then there's some other newer checkpoint drugs that we're planning to add to the platform as well. So I'd say by the end of the year, this list might expand to 7 or 8 drugs in total, something in that general scope. But essentially right now, looking at the most common immunotherapies, these are the drugs we're actively running. Rob, if you want to go to the next slide. These are some of the potential applications, and I say potential because some of this we have sort of clear data on. Some of this is what clinicians and collaborators have come to us and said, this is where I see utility for this test today. And as the data develops, these things could evolve, expand, and change, et cetera. But I'll just kind of skim through them real quick and describe them. The first is, advanced disease. Anytime a late stage patient is just looking for creative options beyond standard of care, we might be providing valuable new insight on their immune system's response to different immunotherapies. And so we could give some additional insight there on something that may or may not have been a consideration previously. Drug-specific functional readouts, like Rob really spoke to in his presentation, when it's providing a real-time blood-based result to show whether or not a single patient's truly personalized response is mounting a response in reference to one of these specific drugs. So that's a pretty unique data point that otherwise doesn't exist outside of this test. Drug selection and equipoise decision making. And what I mean by equipoise decision making, if those are kind of a new concept to you, is there are roughly 40 different indications across different tumor types where second line recurrent colon cancer is, has 3 or 4 different immunotherapy options approved. There's not really any clear data driving right now the decision to choose one of those drugs over another. They're all sort of equivalently listed. It often comes up to just the doctor's prior experience and preference and which drug they choose there. And so this adds an additional personalized data point measuring your cells against those drugs that might help make that decision between Nivo and Pembro or Pembro and Dostar or whatever the drug options might be. Um, Guiding drug combination and rescue strategies, like we already kind of spoke to, in patients that are not responding to current therapy, this might inform if there's a different checkpoint inhibitor or if adding additional agents like a CTLA-4 or a LAG-3 might help to trigger some immune activation. Refining continuation or discontinuation decisions. For a lot of patients, by the time they reach the threshold of beginning immunotherapy, um, there's a decision to make at some point of between tolerability, whether or not you're kind of getting an ambiguous benefit. How long do I stay on this? And having some clarity from a really simple blood test that says, based on what we can see, you are or are not likely to respond to this drug, might change that threshold for how long you stay on or how quickly you discontinue. And it's just additional personalized information to help make that decision rather than just yours in the doctor's gut. Non-invasive alternative to repeated biopsies. The one thing that we get from a lot of collaborators we talk to is the biomarkers they're working from are at a point in time from a biopsy procedure in most cases that was done at some point in the past. They all know that these sort of immune signals can and often do change over time and in response to different circumstances. But the only way to really actively measure that is to rebiopsy, which is not always realistic. And so being able to get a simple blood test with a 3-day turnaround time to give some indication as to whether or not there's a likelihood of a response here could either, you know, justify that biopsy a little more fully, or may just provide enough information on its own to help make that decision. And then, supporting neoadjuvant immunotherapy decisions, much like the example of what we rolled out in that melanoma cohort. There's clear data to show that we can predict the likelihood of response for those patients in a neoadjuvant environment. But often when neoadjuvant decisions are being made, there's a decision to be made of, is neoadjuvant the right choice for me? Or should I go straight to surgery and adjuvant therapy? And if you have an indication that this immunotherapy is unlikely to provide you benefit, you might jump quicker to skipping a neoadjuvant approach and going directly to an adjuvant approach, as an example. Again, these are not all questions that we have specifically individually studied and validated. This is based on what is known of what the assay produces, feedback we've gotten from clinicians and collaborators of areas where they see applications and utility of the test kind of as it is today. And so I thought it was important to share all that. Now, also important to understand in the context of everything that I just said, that if this is an off-label drug situation, even if we show that you might be responsive to Pembro in your circulating systemic immune cells, but you otherwise don't have any clinical indications to get Pembro, our test is not going to is unlikely, I should say, to get that drug covered. You're going to probably need more. But refining decisions in situations where you already know immunotherapy is an option, I think there's a great deal we can add there. And obviously, as our data grows, that situation might change. But today, this is very new. And so, the off-label drug thing is always one to just be aware of, I feel. And then Rob, I think the last slide is just kind of quickly the process. So we are really quickly, and then we'll take more questions. Many of you are familiar with the early access program we've had available with our tumor tissue testing. We are running this test through that same program, which means we will be offering it for a limited time, at least, at absolutely no cost, to patients that kind of come to us through advocacy groups, through, different sources where they find us. And you can just reach out to me or us directly. We explain the process to you. We can support you and information to take to your doctor. This is a CLIA approved test. It does require a doctor's order. But often I provide even, a draft email that a patient can send to their doctor to kind of say, hey, I've learned about this test. I'm interested in it. What do you think? And, we'll support you in any way we can. We send you a test kit. Your doctor gets you the blood draw. It comes back to us 24 hours later, with an overnight label that's on it. And then, about 3 days after that, we would return those results to your doctor, like the ones that I showed earlier. We are opening a clinical IRB approved registry that Rob also briefly spoke to. That's not actively open yet, but it's going to be coming really soon. And our real ask in doing the test right now at no cost is that you share with us your experience. We can continue to build out our experience, expand our case experience, expand our real world data, all things that are valuable to us as we start to seek things like reimbursement and the like. So, with that, I will stop. I know that there are already a bunch of questions in the notes section here, but we'd love to just have an open discussion and go through these questions with you guys.
Thanks. Let me ask one, and then I'll help you moderate, Dennis.
Great.
That is, who is this ideally for? So obviously you've done it in melanoma. So if I were a melanoma patient considering getting an immune checkpoint blockade, that's an obvious use case. How would you generically describe, if I'm a patient saying, well, you've got a free test, all I have to do is go in and get a blood draw. That's a pretty attractive offer. Might give me information, might give me useful information, but I'm not going to do it just, anybody. So who would be the ideal candidate?
Yeah, I think melanoma is a good example because there is a clinical question that has essentially a coin toss right now, where there is equally good data for a patient receiving Pembro as a single therapy versus Ipi and Nivo as a combination, for example, in the neoadjuvant setting. So I think ideally that kind of clinical equipoise question is a really good fit for this kind of test, where essentially an oncologist is in a position where they could give one, two, or three different regimens, but data supports giving any of those three. So additional information about a unique patient's immune response to those drugs could be really valuable. So I think melanoma is a really good example of that. There are a couple other indications, and lung is another one, where there's clinical equipoise, and this kind of information could be immediately helpful for an oncologist.
And this is and that same question that Rob just described, Brad, is true in all MSI high solid tumors. It's true in colon cancer. It's true in rectal, esophageal, gastric, renal, bladder. There's a lot of applications where there is an equipoise decision like that to be made. So our earlier data included a lot of different tumor types, but as Rob described, was just kind of muddy, which is why we went on to do that melanoma specific trial, because it was just a really clean cohort where patients were only receiving checkpoint inhibitors and not other stuff. But because this is looking at the systemic immune cells and not the tumor specific immune cells, we really do have every reason to believe at this point that this is a kind of pan cancer test. But that is something we're going to continue to, investigate and understand as it moves forward. Does that answer the
Yes,
question?
yeah, it does. Let me just sort of build on that. Looking at Alan's question, patients are interested in improving their immune status, often with natural over-the-counter stuff, integrated medicine stuff. Would you baseline T cell fitness assay be something that could be used for that setting, potential application? So I could imagine, like, do I have a healthy immune system? What do you think,
Mhm.
Trevera? And then I could try supplements, or I could try exercise, or I could try meditation over a period of time. I could go in an Ayurvedic clinic. and I come back and I say, did my immune system get boosted? I walk in the woods, whatever, like, could I be getting blood draws every, week, let's say? And I'm trying various experiments on myself in various supposedly immune boosting activities. I'm taking curcumin, whatever it might be. Might that be a use case?
Yeah, I'm going to let Rob respond to that. But I will start by saying I think that it absolutely makes sense. And one of the values of this being a blood test rather than a biopsy is that there are things you can do to change your immune system and your immune response over time. And being able to go back and just get one more blood draw to measure if that has changed could be a really valuable application of this. And in fact, we even see potential applications into things like autoimmune disease and transplant and a lot of other areas that don't use checkpoint inhibitors. But I'm gonna let Rob also comment because I'm sure he has some thoughts around it as well.
Yeah, I think the value of the blood draw is, to your point, is doing the longitudinal collection. So taking a blood draw, looking at the state of the cells, and then after a week, a month, whatever it might be, doing that same measurement again and see if there's a difference in kind of like the functional readout we're getting from the cells. I think we're still in the early days of understanding what those physical measurements mean for just baseline fitness, for example. It's a big reason why we're excited about the registry study, because in addition to the physical measurements of these cells, we're also collecting molecular profiling. So things like gene expression, looking at the phenotype of these cells with flow cytometry. And long term, what we're really trying to do is build the data that shows what that longitudinal profile of a patient's immune system really means biologically. And I think with that in mind, it could be a really powerful tool for helping people guide their own interventions to kind of recraft their immune system in the right direction, for sure.
Okay, I see a question from Rick Davis in the chat. Rick, do you want to just say it out loud?
Go
I'll just say
ahead
it.
and just
Okay.
go ahead and read it out. It's fine.
Okay. Yeah. So can the Trevera technology be applied to understand why certain tumor types are cold? Can we re-engineer T cells to penetrate cold tumors?
So I think there's kind of two different ways of looking at the concept of cold. I think one way it's often looked at is whether or not by pathology, if there are T cells that are sort of physically commingling with the tumor. And for us, that's not really something we're reading out. Because we're looking at blood, we're looking at peripheral cells that are not really involved with the tumor. And so I don't think there's much we can really comment on in terms of that type of tumor hotness, in terms of how they're infiltrating in. But another way to think about whether or not an immune system is hot or cold is how functionally responsive that patient's immune cells might be just generally. And that's something we can potentially pick up with just a blood draw, which is at a sort of baseline level, is this patient's immune system capable of mounting a pretty aggressive response to a threat? And so I think that piece we can get at with the blood test, but not necessarily more of these pathological focusing pieces.
Thanks. Alan Morris has his hand raised.
Sorry, can you guys hear me? I never know how to use this
We
system.
can.
Okay,
We
good.
can.
I'm just curious about your technology. You explained it, but I'm going to try to regurgitate and you tell me where I'm getting things wrong. So you have this crazy measuring device that can do metrics on cells such as density and size and all of that, and that's what you're using to tell whether or not the cell has been activated. Okay, so it's an activation test. Then what you do is you take the person's blood and you get do you isolate their T cells, or are you just running all of their immune cells, which include all the lymphocytes, all the B cells, all the bad T cells, like the T regulators? Are you running them all through this diving board?
So when we're running the test, we do all of the activation in the presence of all of those cells. So it includes the monocytes, all the T cell types. When we run the actual readout, right before we run the readout, we purify the T cells. So effectively what we're doing is we're trying to capture the effect of all those background cells, but using the T cell readout as like the clean endpoint, essentially.
And specifically, are you segregating out the CD3, CD8 potentially as the marker of or signature or cytotoxic T lymphocytes from all of the T regs, which are the generic word for the bad T cells? Are you segregating that out?
So we're actually doing pan T cells. So this is just CD3 isolation. So that will include CD4, CD8, the Tregs, based on some. Sorry.
May I suggest, I'm not a molecular biologist, but I'm just thinking, may I suggest if you were to isolate CD3, CD8 cells in particular, your area under the curve might improve. I'm just throwing that out there. Does that make any sense?
It does, absolutely. We're actually actively trying to answer that question now. So we have another cohort of that same melanoma group of patients. For that cohort, we're going to be performing single cell RNA sequencing for all of the cells that we're measuring in our device. And we're trying to answer that exact question is, are there subsets of T cells that are more informative to this readout that we should be purifying? So it's a great question for sure.
Okay, now I'm still trying to understand. So you have this measuring device, you're passing the person's peripheral blood, trying to look at subsets of lymphocytes, maybe even T cells in general. Um, the test you're doing is baseline, you're activating their T cells with some sort of activating agent, and then you're doing a test activating their T cells with Keytruda or some immune checkpoint inhibitor. Is that what you're doing? You're doing a baseline activation. Geez, this person's cell size and density and all that is increasing with the generic activator. That's their baseline T cell response. And geez, when we add Keytruda, it's even higher. Is that basically the differential you're looking at?
Yep, that's exactly right. And so this is a little bit in the weeds, but the way we're doing that activation, so typically a T cell requires two signals to become activated. The first is antigen, so it has to use its T cell receptor to find kind of a target. And then the second signal is co-stimulation. And so what we're doing is we are providing signal one. We're giving anti-CD3, which essentially just activates the T cell receptor. But all of the co-stimulation is coming from the background population of cells that the T cell is experiencing. And so the kind of working theory is that by adding in a checkpoint blockade drug like Pembro, that background signaling starts to get tilted more and more towards co-stimulation and away from suppressive signaling. And so if that's working, we expect the activation to be a bit stronger. So you're absolutely right in terms of what the structure of the assay looks like.
Thank you.
All right. Richard Anders, you had a question in the chat. Do you want to give voice to that?
Yes. Yeah, sure. I had a couple of comments about sort of how the product would be used clinically, but just the standard question always is, how do you avoid overfitting data? I mean, you have a really limited data set and endless numbers of parameters. What are you going to do to turn that into a test that there's confidence is really actionable?
Yeah, no, that's a great question. I think for us, the way we focus this initial cohort is because we were only around 20 patients or so, we've limited the analysis to just two parameters. So we're looking at the mass and the volume of these cells that we're actually measuring the readout for. And with those two parameters, we also ran cross-validation for the data that I showed, just to leave a subset of those samples out while kind of building this predictor for that model. So it's something that it's a very fair point for us. Another caveat there is right now the AUC measurement, for example, is 0.8, but because it's such a limited data set, the confidence interval on that is quite high. And so what we need to do next is kind of just build out that data set with more patients. Right now, it seems like with around 85 to 100 patients, that confidence interval will get small enough that we'll be pretty confident that we're performing above kind of the standard in the field right now, which is tumor mutation burden. So that's kind of our target, and that's samples we have in the freezer that we're kind of actively working through. So hopefully that data will hold up.
And,
Yeah, I mean,
the good news is also, Richard, just to add to that really quickly, the good news is the academic collaborators that we've worked with are really excited about how unique our specific measurement is. So we've already gotten verbal commitments that we're working through, the specifics of around 1,500 additional specimens in a variety of different tumor types. And so we expect this data set to grow very rapidly.
Yeah, I mean, I think it's really exciting and would be clearly valuable. The details of sort of how you fit the data are kind of lost in the development process. I mean, there are 2 parameters you say, but you're looking at a lot of cell types. So all of a sudden there are more than 2 parameters, and you might have looked at 5 parameters, but threw out all but 2. And then the test result now just uses 2. So it's not quite the same as saying we only started with 2. We ended with 2, but we didn't. We started with a lot more parameters. But if you stick to a fixed formula at this point, and then start looking at a lot more data with a fixed formula, then it'll clearly be a much more robust, statistically valid test.
One more.
But you know that.
We'll start wrapping up here, but Bill Passman had a question in the chat. Bill, do you want to say it to us?
You mentioned in a slide you have there were 17 out of 21 responses, which showed which was promising. But I was wondering if you got a little bit more color on that. Were there particular cancers that this thing worked better for than others, and why is it didn't work? It's a stupid question, but why didn't it work 100% of the time? What if you could talk to that? I'd appreciate it.
Yeah, for sure. So it's not a stupid question. I think our goal is to get it to work 100% of the time. So those misses are really the core focus for any of these. The data we were showing is actually only in melanoma. So this is entirely a cohort of melanoma. So those 21 patients are all a single malignancy. In terms of the misses, one thing we think is not being captured by blood is whether or not there is something for the immune system to target. So this is where that tumor mutation burden piece comes in, where we were able to improve the accuracy of prediction by also layering in the tumor mutation burden for these patients. And so I think as we get more data, we'll find other pieces that hopefully kind of rise that tide and get the accuracy higher and higher. But that's absolutely the goal, is to find the sort of combination of biomarkers that makes us able to predict this for every patient, whether or not they'll respond.
So let me repeat what I heard you say. In essence, you're kind of only measuring one thing. And as a result, since it's a complicated process, there's a couple of factors that'll go on to determine whether or not a drug is going to work. And you only measure the one. It seems like it's a pretty, high order bit in terms of figuring out what the response is going to be. But you've got some other bits you need to figure in first. Is that what you said?
Yep, that's exactly right.
Thank you.
Okay. In spirit of wrapping up, I always like to give the discussion leaders a chance for any final words of wisdom or summary thoughts you'd like to leave with us. Dennis and Rob.
Yeah, I'll start, and then Rob, if you've got anything to add, great. But first of all, thank you guys for hearing us out. This is always a fun group. You guys ask excellent questions, guys and gals. Sorry, I'm a Southerner, so it's a general term for me. But I just included my email address. It was on the screen earlier, but I just put it in the chat as well. Anybody that is interested in talking about this more, getting some questions answered, seeing if it works for them, for providers, clinicians, if you have patients you think you might like to try this in, or research ideas you have, we're really open to those kinds of conversations. As I said, we are offering the test at no cost right now. It is CLIA approved. And so, we can do that. And we're happy to run those sort of experiments. But the data is encouraging and early. So there's plenty we don't know. And we're going to continue to build out these cohorts of interest. We're going to continue to build out these, validations, and, we're going to continue to grow this data, hopefully very deeply and very rapidly. What's nice about this versus our old, our other sort of cancer cell specific test, is that we can do this from frozen blood specimens, frozen PBMCs, which for existing immunotherapy cohorts, that's why I mentioned we have commitments of about 1,500 unique patient specimens. There's a whole lot of stuff in biobanks around the country that we're going to have an opportunity to test very quickly that already have all the clinical outcomes tied to them. So that's something that's going to allow us to build this really, really fast. But those are the top levels. I really enjoyed it, and we appreciate the opportunity.
Yeah, thank you all for the time. It's very helpful. As Dennis mentioned, collecting evidence is really our biggest point. Based on your guys' questions, it's clear you're clear-eyed about what this is and where it needs to go to improve and get evidence. And we need partnership to do that, and sort of working directly with patients that are thoughtful about what this means is very, very helpful for us. So we really appreciate the time.